There's a quiet assumption that follows most prescriptions. If a medication was safe when it was first given, it stays safe over time. I'm Dr. Warren Hung. And in clinical practice, one of the most important shifts I see is not when a new disease appears, but when the body starts responding differently to things that once felt completely routine. If you're interested in understanding how your body changes with age and how to protect it in practical, medically grounded ways, consider subscribing. This channel is here to help you see what often goes unnoticed until it becomes a problem. A medication doesn't need to change to become riskier. Your body does. And that shift is subtle enough that most people never feel it happening. At a younger age, the body is more forgiving. The liver processes medications efficiently. The kidneys filter waste at a steady rate. The brain is less sensitive to chemical fluctuations. There's a kind of built-in buffer, what clinicians often think of as physiological reserve. That reserve doesn't disappear overnight. It narrows slowly. By the time someone reaches their 60s, and especially beyond, several systems that handle medications are working differently. The liver may still function within normal ranges on lab tests, but its ability to break down certain drugs can be slower. The kidneys, measured by something called glomerular filtration rate, or GFR, gradually lose filtering capacity. Large population data, including analyses from NHANES, National Health and Nutrition Examination Survey, show that average kidney function declines steadily with age, even in people without diagnosed kidney disease. And the brain becomes more sensitive to medications that affect alertness, balance, and memory. What this means in practical terms is simple, but often overlooked. The same dose can have a stronger effect. The same medication can stay in the body longer. The same combination of drugs can interact in ways they didn't before. And none of this necessarily feels dramatic at first. It can look like something ordinary, feeling slightly more tired during the day, taking a bit longer to regain balance after standing, forgetting where something was placed and assuming it's just normal aging, sleeping more deeply but waking up less refreshed. These changes are easy to dismiss because they don't immediately feel dangerous. But in clinical practice, these are often the early signals that the body is handling medications differently than it used to. There's another layer to this that makes it even harder to notice. Over time, medications tend to accumulate not just in the body, but in daily routines. A drug for sleep, another for blood pressure, something for pain, something for acid reflux. Each one added at a different point, often for a good reason. But when these are taken together, the effects are not always independent. This is what clinicians refer to as polypharmacy, taking multiple medications at the same time. And large observational data, including analyses from the American Geriatric Society, show that the risk of side effects increases significantly as the number of medications increases, even when each drug is individually appropriate. It's not just about one medication being bad. It's about how the system behaves as a whole. A sedating medication may not seem like a problem on its own. But combined with a blood pressure drug that lowers standing pressure slightly and a sleep aid that affects alertness, the result can be something much more serious. An increased risk of falls. And falls are not minor events after 60. According to the CDC, falls are one of the leading causes of injury-related hospitalization in older adults. What makes this particularly important is that the risk often builds quietly. There isn't always a clear warning sign. No sharp pain, no obvious reaction, just a gradual shift in how the body responds. And because the medications themselves feel familiar because they've been part of the routine for months or years, it doesn't immediately occur to people that they could be part of the problem. This is where clinical judgment becomes essential. Not every medication needs to be stopped. Many are necessary and beneficial. But some medications, especially in certain age groups, require a second look. Not because they are inherently dangerous, but because the body they are acting on has changed. And when that change is not recognized, the risks are often misattributed. A fall is blamed on clumsiness. Confusion is blamed on aging. Fatigue is blamed on poor sleep. When in reality, the underlying issue may be something much more specific and much more manageable. In the next section, we're going to look more closely at what actually changes inside the body after 60 and why those changes make certain medications behave very differently than people expect. But to understand which medications become more risky, you first need to see how the body itself becomes more sensitive and where that sensitivity shows up. When a medication is prescribed, it's usually based on how that drug behaves in the average adult body. But there's a detail that often gets overlooked. The body at 65 is not processing medications the same way it did at 40, even if lab results still look acceptable. This is not about disease. It's about physiology changing quietly over time. Let's break this down into the systems that matter most. First, the kidneys. The kidneys act as a filtration system. They remove waste, but they also clear many medications from the bloodstream. That filtering capacity is measured using something called glomerular filtration rate, or GFR. Large datasets, including the Chronic Kidney Disease Epidemiology Collaboration, CKD-EPI, and NHANES analyses, show that GFR declines gradually with age, even in people without diagnosed kidney disease. What that means in practical terms is this. A medication that is cleared through the kidneys stays in the body longer. So even if the dose hasn't changed, the exposure inside the body increases. This is one of the most common reasons older adults experience stronger or prolonged effects from medications that previously felt mild. Second, the liver. The liver is responsible for breaking down many drugs before they are eliminated. With age, liver blood flow tends to decrease. That doesn't always show up clearly on routine lab panels, but it changes how efficiently certain medications are metabolized. The result is similar to what happens with the kidneys. Drugs can linger longer. Their effects can accumulate. And peak levels may be higher than expected. Third, the brain. This is one of the most important and least discussed changes. The brain becomes more sensitive to medications that affect the central nervous system. This includes sleep medications, anti-anxiety drugs, certain pain medications, antihistamines. The American Geriatric Society Beers criteria, one of the most widely used clinical guidelines for medication safety in older adults, specifically highlights increased sensitivity to these drug classes. What does more sensitive actually mean? It means stronger sedation, slower reaction time, impaired balance, reduced attention, increased confusion. And these effects can occur at standard doses. This is why something as simple as a nighttime medication can increase the risk of falling the next morning. Now, layer these changes together. A drug stays longer in the bloodstream. It reaches the brain more effectively. The brain responds more strongly to it. The combined effect is not just additive, it's amplified. And this is where many people begin to notice changes that don't immediately point back to medication. A slight unsteadiness when walking, feeling mentally slower in the morning, needing more time to wake up fully. These are often interpreted as normal aging, but in many cases, they are the result of how medications are interacting with a changing body. I remember a patient in his early 70s who came in describing what he called a loss of sharpness. He wasn't confused, he wasn't disoriented, but he felt slower, especially in the mornings. He had recently started a medication to help with sleep. It was considered a standard option, and at his age, it didn't raise immediate concern. But when we reviewed his full medication list, something became clear. That sleep medication, combined with a blood pressure drug and a mild anti-allergy medication, was creating a layered effect on his nervous system. Each one individually seemed reasonable. Together, they were affecting alertness, coordination, and mental clarity. When we adjusted the regimen carefully, not stopping everything, but modifying timing and selection, his symptoms improved. And this illustrates something important about how the body works. It's not always a single medication causing a problem. It's the interaction between reduced clearance, increased sensitivity, multiple overlapping effects. This is why guidelines like the Beers criteria don't just list dangerous drugs. They identify medications that become potentially inappropriate under certain conditions, especially in older adults. Not because they are always harmful, but because the margin of safety becomes narrower. And when that margin narrows, small changes can have larger consequences. There's another layer that makes this even more relevant. As people age, physiological reserve decreases. That means the body has less ability to compensate when something is slightly off. A younger person might feel mildly drowsy and recover quickly. An older adult with less reserve may lose balance, fall, experience prolonged confusion, take longer to recover, and those consequences matter. Because they can lead to a chain of events, injury, hospitalization, reduced independence, that started from something as simple as how a medication was processed. This is why understanding the mechanism matters. Not to create fear, but to create awareness. Because once you see how the system works, you start to recognize where adjustments can make a real difference. In the next section, we're going to move from physiology into something much more practical. We'll go through the first 3 medications that I would be very cautious about in anyone over 60, especially when they are used long-term or without regular reassessment. And once you see how common these medications are, you may recognize them immediately in your own routine or in someone close to you. Now that you've seen how the body changes, the next step is practical. These are not rare medications. They are widely used. Many people take them for years without thinking twice. And that's exactly why they deserve a closer look. 1. Diphenhydramine, Benadryl, and similar first-generation antihistamines. This is one of the most common medications people continue using without realizing how strongly it can affect the brain after 60. It's often taken for allergies, sleep, cold symptoms, and because it's available over the counter, it feels harmless. But diphenhydramine has a specific property that becomes more important with age. It strongly blocks something called acetylcholine. Acetylcholine is a neurotransmitter. The brain uses it to support memory, attention, alertness. When this system is blocked, the effects can include drowsiness, slower thinking, confusion, dry mouth, and constipation. In younger adults, this may just feel like mild sedation. In older adults, the same mechanism can have a much stronger impact. The American Geriatric Society Beers criteria specifically lists diphenhydramine as potentially inappropriate in older adults because of these anticholinergic effects. And the risk is not just short-term. Long-term observational data, including studies from the Adult Changes in Thought Act cohort, have found that higher cumulative exposure to strong anticholinergic medications is associated with an increased risk of cognitive decline. That does not mean a single dose causes harm, but it does mean repeated use, especially for sleep, can create a pattern that affects brain function over time. There's also a physical risk. Because it causes sedation and slows reaction time, it increases the likelihood of nighttime falls, morning grogginess, impaired balance. Who is most vulnerable? Adults over 65, anyone already experiencing mild memory issues, people taking other sedating medications. What to discuss with a doctor? Whether a second-generation antihistamine, like loratadine or cetirizine, would be more appropriate for allergies. Non-drug approaches for sleep. The key point here is not that this medication should never be used. It's that regular use, especially for sleep, deserves reconsideration after 60. 2. Benzodiazepines, such as diazepam, alprazolam, lorazepam. These medications are commonly prescribed for anxiety, insomnia, muscle tension, and they are effective at what they do. They calm the nervous system by enhancing the effect of GABA, a neurotransmitter that slows brain activity. But this calming effect becomes much stronger and less predictable as the brain becomes more sensitive with age. The Beers criteria and multiple clinical guidelines highlight benzodiazepines as higher risk in older adults. Why? Because they affect several systems at once. They reduce alertness. They slow reaction time. They impair coordination. They affect memory formation. And in older adults, these effects can persist longer because the drug is cleared more slowly. This creates a combination that is clinically significant. Increased fall risk, higher likelihood of fractures, episodes of confusion or disorientation. Large observational studies, including analyses published in JAMA Internal Medicine, have shown an association between benzodiazepine use and increased risk of falls and hip fractures in older adults. There is also ongoing research into their relationship with cognitive decline, although findings are mixed and still being studied. So this is an area where it's important to be precise. The concern is not just the medication itself. It's duration of use, dose, combination with other medications. Who is most vulnerable? Adults over 65, those taking other sedating drugs, individuals with balance issues. What to discuss with a doctor? Whether the medication is still needed, whether the dose can be reduced, whether non-benzodiazepine approaches for anxiety or sleep are appropriate. It's also important not to stop these medications abruptly. They require careful tapering under medical supervision. 3. Non-steroidal anti-inflammatory drugs, NSAIDs, such as ibuprofen and naproxen. These are among the most commonly used medications worldwide. They are taken for joint pain, back pain, headaches, inflammation, and they can be very effective. But long-term or frequent use after 60 carries risks that are often underestimated. NSAIDs work by blocking enzymes called COX-1 and COX-2, which are involved in inflammation. But these enzymes also play protective roles in the body. When they are blocked, several things can happen. The stomach lining becomes more vulnerable to irritation and bleeding. Kidney blood flow can be reduced. Fluid retention can increase. Clinical data, including guidance from the American College of Cardiology and FDA safety communications, have linked NSAID use, especially at higher doses or longer durations, to increased risk of gastrointestinal bleeding, worsening kidney function, increased cardiovascular risk in certain populations. And again, age changes the context. After 60, kidney reserve is lower. The stomach lining is more fragile. Many people are also taking medications like blood thinners or steroids, which amplify risk. This combination can turn what feels like a simple pain reliever into a source of cumulative stress on multiple systems. Who is most vulnerable? Adults over 60. Those with kidney disease. Those with a history of stomach ulcers. People taking anticoagulants or steroids. What to discuss with a doctor. How often NSAIDs are being used. Whether alternative pain strategies are appropriate. Whether kidney function should be monitored. The goal is not to eliminate effective pain relief. It's to use it with awareness of how the body's tolerance has changed. At this point, a pattern should be starting to form. These medications are not unusual. They are part of everyday routines. And each one, on its own, may seem reasonable. But when combined with age-related changes in metabolism, sensitivity, and physiological reserve, the margin for safety becomes smaller. In the next section, we'll complete the list with 2 more medications and then step back to understand what all 5 of these have in common and how to recognize risk before it becomes a problem. And this is where the pattern becomes clearer, because it's not just about individual drugs, it's about how they interact with a changing body. We've already looked at 3 very common medications, and none of them are unusual. None of them are rarely used. In fact, that's exactly why they matter. The next 2 follow the same pattern, but in a way that's often even less obvious. 4. Proton pump inhibitors, PPIs, such as omeprazole, esomeprazole. These medications are widely used for acid reflux, heartburn, stomach protection, and in many cases, they are very effective, especially for short-term use. They work by reducing stomach acid production. That sounds straightforward. But stomach acid is not just there to cause discomfort. It plays important roles in the body, helping digest proteins, absorbing key nutrients, protecting against certain infections. When acid is reduced for long periods, several downstream effects can appear. Long-term observational studies and clinical reviews, including those referenced in guidelines from organizations like the American Gastroenterological Association, have associated prolonged PPI use with reduced absorption of vitamin B12, lower magnesium levels, increased risk of bone fractures, higher susceptibility to certain infections, including Clostridioides difficile. Now, it's important to be precise here. These are associations, not guarantees. Many people take PPIs without experiencing major issues, but the risk profile changes when use becomes long-term. The original reason for prescribing is no longer reassessed. Age-related vulnerability increases. After 60, bone density often declines. So even a small increase in fracture risk becomes more meaningful. And nutrient absorption becomes more important, not less. Because deficiencies can contribute to fatigue, nerve issues, cognitive changes. Who is most vulnerable? Adults over 60 using PPIs long-term. Individuals with osteoporosis or fracture risk. Those with already low nutrient levels. What to discuss with a doctor. Whether the medication is still needed daily. Whether the dose can be reduced. Whether intermittent use is appropriate. Whether underlying causes of reflux are being addressed. The key idea is not to stop a useful medication. It's to avoid using it indefinitely without reassessment. 5. Sulfonylureas, such as glyburide, glipizide, diabetes medications. These medications are used to lower blood sugar by stimulating the pancreas to release insulin. They can be effective, but after 60, they carry a specific risk that becomes much more important. Hypoglycemia, blood sugar dropping too low. This is not just a mild side effect. It can lead to dizziness, confusion, fainting, falls, in severe cases, loss of consciousness. The American Diabetes Association, ADA Standards of Care, emphasize that older adults are at higher risk of hypoglycemia and often require more conservative treatment targets. Why does this risk increase with age? Several reasons. Kidney function declines, so the medication may stay active longer. Appetite patterns may change, leading to irregular food intake. The body's ability to recover from low blood sugar becomes less efficient. And importantly, the warning signs of hypoglycemia may be less noticeable. A younger person might feel shaking, sweating, rapid heartbeat. An older adult may instead feel mild confusion, fatigue, subtle dizziness, which can easily be mistaken for something else. This is where the risk becomes hidden. Because the signal is quieter. Who is most vulnerable? Adults over 65. Those with irregular eating patterns. Individuals with kidney impairment. Those living alone. What to discuss with a doctor. Whether this class of medication is still the best option. Whether newer alternatives with lower hypoglycemia risk are appropriate. Whether blood sugar targets should be adjusted. Again, the goal is not to remove treatment. It's to match treatment to the current physiology. What these medications have in common. At first glance, these 5 medications seem completely different. Allergy medication, anxiety medication, pain relievers, stomach acid treatment, diabetes drugs. But when you step back, a pattern becomes clear. Each of them interacts with systems that become more sensitive or less stable with age. The brain, the kidneys, the metabolic system, the balance and coordination system, nutrient absorption. And each one has a risk that often develops gradually, not suddenly. That's why these problems are frequently misinterpreted. A fall is blamed on age. Fatigue is blamed on sleep. Confusion is blamed on memory decline, when in reality, the medication may be part of the picture. There's another shared feature. Most of these medications are not reevaluated regularly. They are started for a valid reason, and then they continue. Months turn into years. And the question of, do I still need this at the same dose in the same way, is never revisited. This is where clinical awareness becomes powerful, because recognizing the pattern allows for early correction. Before a fall happens, a hospitalization occurs. Independence is affected. And importantly, this is not about removing helpful treatments. It's about adjusting them to match a body that is no longer the same as it was decades earlier. In the final section, we'll bring all of this together into something practical. How to review medications safely. What to look for starting today. And how to have a clear, medically grounded conversation with a doctor about what should stay, what should change, and what should be watched more closely. And this is where awareness turns into action, because once you recognize the pattern, you can start making decisions that protect your health in a very real way. At this point, the goal is not to remember 5 medications and become concerned about all of them. The goal is to understand how to think about medications differently after 60. Because the real protection does not come from avoiding every risk. It comes from recognizing where the body has changed and adjusting decisions to match that change. Let's turn everything we've discussed into something practical. 1. Start with a simple medication review. Choose one moment this week. Lay out every medication being taken. Prescriptions, over-the-counter drugs, sleep aids, allergy medications, supplements, and ask one clear question for each. Is this still necessary in the same way it was when it was first started? Not. Is this a good medication? But, is this still appropriate for my current body? Because time changes the answer. 2. Identify the high-risk categories. You don't need to memorize drug names. Instead, look for patterns. Be more cautious if a medication causes drowsiness or affects alertness, is used for sleep or anxiety, is taken daily for pain, is used long-term for acid suppression, lowers blood sugar aggressively. These categories map directly to the systems that become more sensitive with age. The brain, balance and coordination, kidney function, metabolic stability. If a medication fits one of these categories, it doesn't mean it should be stopped. It means it deserves a second look. 3. Watch for subtle signals the body is giving you. The body often signals medication-related stress quietly. Pay attention to patterns like feeling unsteady when standing or walking, needing longer to feel alert in the morning, increased forgetfulness or slowed thinking, unusual fatigue during the day. Episodes of lightheadedness. These are often dismissed as normal aging, but they are also common early signs that a medication dose may be too strong, the timing may not be ideal, or multiple medications are interacting. Catching these early can prevent more serious outcomes later. 4. Bring specific questions to your doctor. A medication review becomes much more effective when it is focused. Instead of asking, "Is everything okay?" ask, "Do I still need this medication at the same dose? Is there a safer alternative at my age? Could this be contributing to my fatigue or balance issues? Should my kidney function or labs be checked again? Is this medication still appropriate long-term?" These questions shift the conversation from routine continuation to active reassessment. And that's where meaningful adjustments happen. 5. Avoid abrupt changes without guidance. This is important. Some medications, especially those affecting the brain or blood sugar, should not be stopped suddenly. Doing so can create new risks. The safer approach is review, adjust gradually, monitor response. This is a collaborative process. 6. Think in terms of systems, not single drugs. What we've discussed is not about isolated medications. It's about how they interact with a slower metabolism, reduced kidney clearance, increased brain sensitivity, lower physiological reserve. When you start thinking this way, the question changes from, "Is this drug safe?" to, "How is my body handling this entire combination now?" That shift alone can prevent many of the problems clinicians see later. A simple weekly checklist. You can use this as a quick mental check. Am I taking anything that makes me drowsy or less alert? Have I added new medications in the past 6-12 months? Have I noticed subtle changes in balance, memory, or energy? Has my medication list been reviewed recently with my doctor? If the answer to any of these is yes, it's worth a closer look. There's a pattern I see repeatedly in clinical practice. The issue is rarely that someone was given the wrong medication at the start. The issue is that the body changed, and the medication plan did not change with it. And that gap is where problems begin. When you close that gap by reviewing, adjusting, and staying aware, you don't just reduce risk. You protect independence, clarity, and quality of life. If this helped you see your medications in a new way, you can subscribe for more explanations like this, focused on how the body actually works and how to make practical decisions from that understanding. And if you're comfortable, let me know in the comments which of these medications or patterns sounded familiar, or what you'd like explained next. The most useful step from here is a simple one. Take a few minutes, look at your current medications, and ask whether they still match the body you have today, not the one you had years ago.